or it's my pleasure to introduce her this morning. We're going to have an update in urology. She did her undergraduate in medical education at the University of Virginia before she then traveled to the Midwest, where she did her urology residency at Washington University School of Medicine at Barnes Jewish Hospital. And then she traveled further west, where she went to UCLA to do a female pelvic medicine and reconstructive surgery fellowship there before she then traveled to Denver, where she became an assistant professor of urology last year and is currently active in the urogynecology practice here. So give us 1 minute, we'll change computers, and then we'll get started again.
Thank you very much.
You need to sign in.
Yeah. There we go. Okay. Okay. Sorry, guys. All right. Well, hopefully this will. I can see it. There we go. All right. So I'm going to talk about the surgical management of female stress urinary incontinence in 2018. And I have no disclosures. Our objectives for today are to summarize the prevalence and evaluation of female stress incontinence, to identify the various surgical treatments we have available for the treatment of stress incontinence, and to improve the understanding of the complications related to synthetic midurethral slings. Stress incontinence, as you may or may not be aware, is defined by the International Continence Society as the complaint of involuntary leakage on effort or exertion, or on coughing or sneezing. It affects both men and women across the globe. It's much more common in women. In men, it's typically related to prior prostate surgery or a neurologic condition. It affects women of all ages, from young female athletes to women during pregnancy and postpartum. Postmenopausal, the incidence peaks, but it also affects women towards their end of their life. It's extraordinarily prevalent, as high as 50% by most estimates, and it's a very costly condition to our healthcare system and to patients. This study in 2011 estimated that over $12 billion was spent annually in non-surgical and surgical care. Most of the cost is actually related to non-surgical care. About 70% is related to conservative management, and a lot of that burden falls on the patients. This is costs that they have to pay for out of pocket for care or just management of the condition. The social impact is great as well. As one can imagine, it's a very embarrassing and distressing condition for many patients. It often limits what they like to do or can do, such as you can imagine if you were incontinent, going hiking would not be so much fun. So it affects their activities of daily life, can be restrictive as far as what they want to participate in, whether socially or even sexual function. And again, it's very costly, which can also limit their activities because of the cost of managing their condition during those activities. In some cases, it even really isolates the patient, staying at home because they fear of incontinence. So what keeps us continent? What prevents incontinence? Well, it's a complex multifactorial mechanism, most likely. We think it involves a variety of mechanisms, from pelvic floor function, the urethrovaginal support, hormonal roles, mucosal coaptation, function of your sphincters, and neurologic mechanisms as well. and what leads to stress incontinence. I like this analogy. One can imagine if you have pretty strong backboard of support to your proximal urethra, bladder, neck, this can keep you continent. The analogy is if you have a flowing garden hose and you step on that hose against a hard backboard like a rock, you can stop the flow of that hose. Now imagine you lose that backboard of support and you step on that hose against soft soil. It's much harder to compress that hose and keep you dry. So our treatments are geared towards improving this. On the spectrum, we have a big spectrum of treatment of stress incontinence, from less invasive non-surgical treatments to more invasive surgeries. Usually we start with these non-surgical or conservative therapies. Lifestyle adjustments such as weight loss and smoking cessation are very important. We have good data to show that a weight loss, modest 5 to 10%, significantly reduces bothersome incontinence and urinary incontinence episodes. This can be pretty tough for some patients, though. We have a variety of other therapies as well, like pelvic floor physical therapy and intravaginal support devices like pessaries. And of course, there's always pads. Those non-surgical treatments are great for patients with mild symptoms or aren't too bothered, but some patients are more bothered, will desire more definitive treatments. Sort of in the middle of the spectrum, we have urethral bulking. This is a minimally invasive endoscopic procedure we can do in the office or an outpatient surgery center where through a cystoscope we inject a bulking material around the urethra, taking the urethra you see on the bottom left, which is wide open, called a fixed open urethra, inject some material to provide some better coaptation. This is a good option for elderly patients, maybe not a candidate for more invasive surgery, or fixed scarred urethras like that one shown. It does work pretty well, improvement seen in about 60% of patients, but most need re-injections, often multiple. The rates have been described about 50% in a year. So a lot of patients might try these things, but they desire more definitive management, and for that we have surgeries like urethral suspension or slings. Surgery for stress incontinence is a very popular procedure, done in high volumes across the world, actually. In the 1990s, 10 to 13% of female beneficiaries of Medicare underwent at least one procedure to treat stress incontinence. And then there's data from the U.S. National Hospital Discharge Summary in 2003 showing about 12% of American women underwent a stress incontinence surgery of that year. So these procedures really being performed in the U.S. in high volumes. Roughly 1 in 10 women will undergo a procedure in their lifetime. When we talk about surgery for stress incontinence, we often talk about the index patient, and that's who we're going to discuss today. The rest are really outside of the scope, but what do we call the index patient? That's an otherwise healthy female. They have pure stress incontinence, or what we call stress-predominant mixed incontinence, meaning they have minimal symptoms of overactive bladder, which is urgency, frequency, leakage with an urge. They've had no previous history of stress incontinence surgery, no neurologic disorder. They're not particularly elderly. They have no significant pelvic organ prolapse. They can empty their bladder well, and they're non-obese. So really a straightforward, simple, pure stress incontinence patient without complicating factors. In 2018, when we talk about surgical options for stress incontinence, we're really talking about two categories of approaches, the Birch Colpo suspension or a sling. And slings can be made out of two materials, autologous fascia or synthetic mesh. The Birch procedure was described in 1961. It can be performed either open or laparoscopic. It's one of our classic procedures for stress incontinence. It's been very popular for many, many years. This is where the vaginal tissue around the proximal urethra or bladder neck is sutured to the iliopectineal ligament. One of our other classic procedures, more commonly performed by urologists versus the Birch, which is really mostly performed by gynecologists, if you look at the numbers. But for urologists, we have the autologous sling. This was popularized by McGuire in 1978. Very successful, success rates 80+%. You can use either rectus fascia or fascia lata from the thigh through a vaginal incision. The sling is placed and secured to the anterior abdominal wall of rectus fascia. As far as data, we have the sister trial from New England Journal in 2007. It's, one of our largest multi-center trials, 500 patients. After 2 years of follow-up, comparing the autologous sling to the birch, the autologous sling was more effective with a 66% cure rates at 2 years. And you say, why does that sound a little lower? You say 80%. Well, it's a pretty strict definition. So the autologous sling is a little superior to the birch in terms of efficacy. And this really was considered the gold standard for many, many years, and by some would still be considered the gold standard of our surgical procedures for stress incontinence. Then came along the Mid-Urethral Sling. This is a polypropylene synthetic mesh sling, can be placed transvaginally, and really revolutionized the treatment of stress incontinence. There are two approaches. The retropubic sling, in which the arms of the sling are passed retropubically in front of the bladder, and the transobturator sling, which goes out through the obturator frame and into the adductor obturator muscles of the groin. The transobturator approach was developed thinking that this approach would minimize the risk of bladder injury, which could occur with the retropubic approach. How did the mid-urethral sling come about? A bit of a timeline. In the 1950s, you guys are probably more familiar than I, but mesh repairs for abdominal hernias were popularized. Gynecologic and urologic surgeons adopted this to using mesh transabdominally for repair of prolapse. And then in the 1990s, surgeons started to use the mesh to create their own suburethral slings. In 1996, the first mesh kit product, like the one shown here, was approved for the treatment of stress incontinence via 510(k) clearance process. And so again, we have the two types of slings. As far as this one shown to be superior than the other, just to mention, we do have the TOMUS trial, the trial of mid-urethral slings comparing the retropubic and transobturator approaches, first published in 2010, and then subsequent follow-ups up to 5 years, essentially showing, particularly early on, equivalent success rates between the transobturator and retropubic approaches, particularly when looking at objective cure rates. Won't get into too much detail, but as those patients have been followed up, the efficacy did drop off quite a bit in this trial. The retropubic sort of trended towards better efficacy over the 2-year and 5-year data. But nevertheless, a very effective treatment for stress incontinence, became very popular. And more recently, looking back at all the data we have now and this meta-analysis, comparing autologous slings to mid-urethral slings, efficacy is shown to be similar. No difference in overall cure rates and subjective cure rates between mid-urethral sling and fascial slings. So this really revolutionized the treatment of stress incontinence, because compared to in the past with the birch and the autologous sling, we now have a very quick procedure. It can be done in 30 minutes, outpatient. It's minimally invasive. It was had an easier learning curve. It was simple to teach. It was accessible. Now we have this procedure that can be taught to urologists and gynecologists across the world, and the recovery was faster. So everything sounds great. And many, many kits. This is just a sampling of the kits that were developed for these transobturator and retropubic slings. So again, this really revolutionized the landscape and the practice patterns for the treatment of stress incontinence. If you look on the left side of the screen, this is data from Australia, actually, Medicare data, where in Australia this captured all females over the age of 25, essentially, in Australia. And in 1994, you can see the most popular procedure was actually the birch in purple. And then the red arrow shows when mid-urethral slings were introduced. There's a faint blue line at the top that is not showing up. But after the introduction of mid-urethral slings, two things happened. Well, the mid-urethral sling took over, and you can see an almost exponential growth in the performance of those procedures. And with that, you see a decrease in birch. Autologous slings at the bottom in yellow declined a little bit as well, but were not performed as much. And then, yes, what's not showing up is the overall rates of just stress incontinence surgery in general, which, if you follow my arrow, it looks like this. It's very, very hard to see. But what that's showing is not only did mid-urethral slings just take over as the most popular procedure, but we just saw a general increase in the overall volume of stress incontinence surgery. And people have looked at, well, why that is, and they've really been able to tell that that was attributed to the release of the Midurethral Sling. Controlling for things like age, which you might say, okay, well, maybe it was just an effect of the aging population. We were performing more incontinence procedures. No, it was really the introduction of the sling which changed that rate. This is some data from the U.S., the Market Scan Claims database, looking at surgical claims and a commercial payer mix. Again, here shows this is data starting in 2000. So through most of the early 2000s, again, the total number of stress incontinence surgeries just really increased, and most of that was attributed to an increase in volume of sling procedures. And we saw a decrease in all of the other procedures. So again, what is the argument for midurethral slings? Well, as we showed, they have similar efficacy to autologous slings. Great. It's shorter. It's procedure. It's faster. So far, what we know is safe, and it's the most studied procedure to this date. We have much more literature on the midurethral sling than we do on anything else, and there's now more than 3 million slings placed worldwide. But unfortunately, also as we've come to adopt this sling, it does carry with it a unique risk of complications related to the synthetic mesh. The mesh can erode into the urethra, shown top left, into the bladder on top right, which can cause stone formation. The mesh can become exposed in the vagina. All of these complications can present with varying and very distressing symptoms like chronic pain, infections, dyspareunia, pain with intercourse, either the patient or their partner, vaginal bleeding, and even without frank exposure or erosion, unfortunately, there's a small subset of patients that just have chronic pain related to the mesh, which we don't understand well. Some of these complications, we end up removing part or the whole sling. Shown here, this patient of mine, we removed an entire transobturator sling from. So unfortunately, we started seeing these mesh complications. In 2008, after these complications started to be reported through the MAUD database, the FDA issued the first public health notification regarding the risk of serious complications associated with transvaginal mesh. And this notification was both in regards to mesh used for prolapse repair as well as stress incontinence. Then in 2011, they followed this up. They had received almost 4,000 reports in the MAUD database related to injury, death, or malfunction, quote, related to the mesh. And they issued this statement that serious complications associated with surgical mesh for transvaginal repair of pelvic organ prolapse are not rare. And you'll note that that says pelvic organ prolapse, and that's important about this statement. It did refer to pelvic organ prolapse mesh. It did not refer specifically to midurethral slings, but the FDA also specifically stated they were continuing to evaluate them. And nevertheless, this did really influence the landscape. So what happened after this public health notification? This is data from 8 academic centers compiled their trends in stress incontinence surgeries in 2017. You can see that it starts in 2007, but after the 2011 FDA notification with the red star there, the number of midurethral sling surgeries at those institutions started to drop off. Just to show that the number of stress incontinence surgeries stayed approximately the same during this time, so it wasn't attributed to a decrease in volume. And after the 2011 notification, the number of autologous sling surgeries increased. And they also started to see increase in volume of mesh revision surgeries. And this really was representative of what we were seeing across the U.S., at least in academics. But it's not true throughout the community. In particular, there was a 2013 survey of members of AUGS, the American Urogynecologic Society. There were some academics in that survey, but also a lot of private practice practitioners, as well as a lot of people who identify as a urogynecologist. Before the FDA warning, 99% of AUGS members reported using the midurethral sling for their primary stress incontinence surgery, and this did not change following the FDA notification. So the trend was not seen in both the community and academics necessarily. So these complications continued. and have really been the subject of some media debate as well. You've probably heard of the 60 Minutes episode, and particularly actually outside the U.S., the Mid-Urethral Sling is coming under some scrutiny. In England, currently the NHS has halted the use of mesh for prolapse and incontinence until there's further review. And Scotland as well has taken it off the market. New Zealand and Australia have made it very difficult for people to use mid-urethral slings at the moment as well, until there's further study. So this has led to our main professional societies, OGS and SUFU, which is kind of the urology side of urogynecology. Won't read this whole statement, but currently the mid-urethral sling in the U.S. is still considered the gold standard. They say, we are concerned that the multimedia attention has resulted in confusion, fear, and an unbalanced negative perception. This negative perception is not shared by the international medical community and the overwhelming majority of women who have been satisfied by their mid-urethral sling, which is true. These complications affect a relatively small proportion of women. Furthermore, the FDA website states that the safety and effectiveness of multi-incision slings is well established in clinical trials that followed patients for up to 1 year. So with sort of this changing landscape, how do you choose a sling procedure? Well, mesh is great. It takes less time. It's simple. It's performed by surgeons, gynecologists, urologists around the world, has a short learning curve, easier to teach, and it's endorsed by our professional societies as the gold standard. Fascial slings take over twice as long to perform. It's a more complex procedure. There's just less folks trained to perform them. It's a little bit of a longer hospitalization and recovery. There might be higher rates of voiding dysfunction. We didn't get into that, but some debate over that, and possibly greater surgical morbidity. Mesh, however, again, carries this small but unique risk of mesh complications. You have mesh erosion, exposure, possibly infection, chronic pain, and dyspareunia. Again, these are small subset of patients we talk about that are affected by these problems, but when they do happen, they're really life-altering and possibly not reversible or treatable by mesh removal, for example. Fascia, again, has those. It's a little bit more involved, but it doesn't carry that risk of mesh complications. I like to say not all risks are created equal, and how patients view these risks and benefits really depends on the patient. Some recent data from the International Continence Society meeting this past summer. Dr. Blavis studied the safety of autologous fascial slings versus synthetic slings, going back, reviewing the literature from 1978. Interestingly, they actually showed that really there's looking at safety of the procedure, risks related to the procedure itself, like bladder perforation, wound complications, really not much of a difference. Now that looking back at all of our literature, really the only place we see a difference is in those unique risks of mesh, like erosion requiring surgery. You can see there, vaginal, bladder, urethral erosion, and even, surprisingly, a higher risk of de novo OAB with the synthetic mid-urethral slings, not the fascial slings as we used to once think. We're learning more and more about maybe who shouldn't have a mesh sling, as far as how can we mitigate those risks of mesh complications. I think this is mostly expert opinion. It's an area that needs more study, but we most agree that mesh should not be placed when you're doing a concomitant urethral reconstruction, such as a fistula repair. And then there are some groups we've identified that probably aren't the best candidates for a mesh sling. Comorbidities that result in poor wound healing, diabetics, smokers, maybe immunosuppressed patients, obesity even, prior pelvic radiation, prior pelvic surgery that's resulted in severe scarring, other conditions that lead to poor tissue quality, and certainly a history of mesh complications. I personally use caution in any patients with systemic or chronic pain conditions, but overall this is an area that needs more study. So what's the best sling, if you ask me? Well, it's the one that the patient feels is best for her. It's a long discussion, but it's an individualized, informed, and shared decision-making process tailored to the patient's specific preferences and risk tolerances. So in conclusion, stress incontinence in females, it's highly prevalent. It's quality of life altering. The surgical management and the landscape of surgery is changing and evolving. In the U.S., the synthetic sling is considered the gold standard, but it is associated with a not rare risk of mesh-related complications. And these are lifestyle altering when they occur and can be very challenging to treat. So women should be informed of all the choices available to them and the pros and cons of each. So thank you.
Try to use the microphone so the remote site can hear the question.
Yeah, Dr. Oliver, I really appreciate your lecture, and this is a really important topic. I think you did a really good job going over the position statements and trying to kind of clear the air, because there's a lot of misinformation out there right now on stress incontinence. And certainly the trend was for more surgery up to 2008, and now there's been a dramatic decrease in surgery overall since not just in mesh, but in things in general. So my question is, what services do you offer in your practice? You have a patient that comes in. I know you're a big advocate of joint decision-making. Are you comfortable offering them mid-urethral slings, autologous slings, bulking?
Yeah. I feel I should fully disclose my training, because we're in the area of what we call female pelvic medicine and reconstructive surgery is my fellowship training. And there, if you look at all the programs, all of us are exposed to differing amounts of all of these procedures, and we come with certain biases. And I think it's very honest to disclose that with patients. So I offer them, to answer your question, I offer patients both full range from bulk, lifestyle modification, big advocate of pelvic floor physical therapy, bulking, surgeries, both the retropubic, mid-urethral sling, and fascial sling. I do not offer patients transobturator sling, but that's another discussion. But I disclosed with them that I did train at a center that we saw a high volume of mesh complications. I do offer patients the autologous fascial sling as a primary procedure for stress incontinence, which is probably not as common throughout the country. But I think patients be fully aware of the complications that can be seen related to mesh. They do affect only a few percentage of women undergoing the sling. There are many thousands, tens of thousands, hundreds of thousands of women throughout the world happy with their mid-urethral sling, but I think they need to be aware of what may be required to fix those complications should they occur.
Yeah, I agree with Dr. Flynn. It was a great presentation. When I think about sometimes the impact that marketing and the introduction of commercial products can have into a healthcare environment, I think one good example is the dramatic shift to robotic surgery for a number of procedures. I think that was partly driven by an extraordinary marketing campaign by the company that makes surgical robots. There's a lot of interest now in the management of Peyronie's disease, now that there's a commercial product available to treat Peyronie's disease, and a lot of marketing is going into that. When I look at the number of incontinence procedures that started occurring at about the time that products that were patented and could be sold by companies and marketed by companies came online, do you think that sort of marketing had an impact on the tremendous upsurge, upswing in interest, which could be good or bad? I mean, marketing introduces people to the concept that there are effective treatments available, but it sometimes, I think, pushes decision-making based on perhaps unrealistic expectations that patients have based on marketing. Any thoughts about how that might have impacted the marketplace during that huge upswing?
I think you're right. There is certainly the view that, yes, all of a sudden we had this procedure that was more accessible to patients, which in healthcare is generally a good thing. It gave women who were highly bothered and a distressing condition access to this minimally invasive procedure. But I wasn't around for it myself, but what I've heard is, yes, marketing also may have played a role in a not so great way, in that I've heard that these slings were often taught to physicians in the quote-unquote weekend course method. And again, they were approved by the 510K process, so not necessarily with a lot of human data. They really piggybacked on the data of abdominal mesh hernia repairs, and that was the process of approval. So once that went through, just marketing exploded, maybe without as much data as one should have, similar to robotic surgery. A lot of the critiques of that are similar in that we adopted robotic surgery with not as much data as perhaps we should have. But I don't know if Dr. Flynn was around, practicing when it was approved with the role of marketing, and I don't know.
One last quick comment.
Sure.
The biggest issue we struggle with in urology, I think in surgery as general, and they probably have done a better job in the American College of Surgeons than in urology, is how to educate physicians in practice on new procedures that become available. And leaning on industry, I think we've learned, is not the best way. We should really lean on our professional societies to educate more experienced physicians on new procedures and whether or not they want to adopt them into their practice, because there's naturally going to be some bias at these weekend industry-sponsored courses. And I think as a specialty, we're gradually, finally moving away from that way of instructing physicians.
While you're bringing the microphone up to Dr. Birnbaum, it seems like for marketing you need a good acronym, you need a robot, and the only thing that can make this better is if you could somehow use a laser. Dr. Birnbaum.
Janine, first of all, it's a great talk. You have mid-urethral mesh and transvaginal mesh. So it seems to me that the only common word in those two is mesh, and not, so is it where you're placing the mesh? Is it the mesh itself, or patient factors? Because when you look at those patients who have complications, is it that an inexperienced person placed it? Did they place it wrong? Or are there more patient complications? Because I don't think the two are the same. I mean,
Prolapse and mid-urethral?
correct.
Yeah. I would say in addition to the word mesh, though, there's one other word in common, and it's transvaginal mesh. Well, it's, there's transvaginal mesh for prolapse and a transvaginal mesh mid-urethral sling. Yeah, it's, as you know, a very controversial area, and some would argue that there's, people have studied, maybe it's low volume, improperly educated and trained people who are putting in slings. And you can find data in support of that and also against that, there was, I can't quote it exactly, but people have studied the volume question, and even low volume surgeons and high volume surgeons, there's data to show have similar rates of mesh complications, suggesting that it's not necessarily expertise. But certainly there are those out there who feel it's technical related. I think it's often, those factors we mentioned, there might just be patient factors that are predisposing to these complications. I know Dr. Flynn has probably seen the patient who gets a mesh mid-urethral sling, then they get breast cancer, they get anti-estrogen treatments, they have extreme vaginal atrophy, their sling becomes exposed, they have complications. So there are probably, not that you can control for that, there's probably patient factors. But there's also, I think, plenty of people putting, they're technically doing everything right, and there are still patients developing these complications, and we don't understand why that is occurring. That's something I'm, personally interested in looking into. But basically, long story short, yes, there's certainly a difference between prolapse mesh and mid-urethral mesh in many ways, but I don't think it's purely technical. I think there's something else going on that we don't understand yet. At UCLA, we were researching the role of infection. Perhaps the vagina cannot be sterilized like the abdomen, the skin of the abdomen. There's data now to show that there is bacteria on these mesh explants, and it's not. It is a biofilm of the mesh. Perhaps that plays a role in chronic pain, but this is really just an area of research. So.
All right, it's after 8 o'clock.
Yeah.
Thank you for attending.